this is Gloria Sanders again. I'm going to try something a little different now. I've had a clinical practice in this area for 35 years, and I want to do a few case reports, and I want to show you what was done to the patient, the physician's orders, and what the patient told me they received in another clinic when they came to me. And I'm going to ask you to grade this. If you were a professor and this was a student, how would you grade it? So the first case report, this particular patient had surgery on their left shoulder. Remember, left. The physician did an arthroscopic subacromial decompression. We often, with shoulder problems, have spurs that grow under the acromion, which can cut the rotator cuff muscles. So cutting those out, removing those, is very common with shoulder surgery. The patient also had an anterior and posterior capsule release. Well, why is that done? That's done because the patient probably had a frozen shoulder. So the sac around the joint, the capsule, was tight, and he did a surgical release. In the past, in my early career, doctors would just put a patient asleep and then just force it, just rip it loose. This particular doctor invented this surgery, I think, but he does a very controlled surgical release of the capsule. He also did a distal clavicle excision. That's done if there's a lot of arthritis at the AC joint. And he did a tendon and labral debridement. The only muscle that was reattached was the biceps. And with shoulder injuries, the long head of the biceps brachii goes into the shoulder joint, and that's often injured and is very commonly reattached. So it's no longer crosses the shoulder joint. They trim the tendon and reinsert the biceps tendon into the the humerus, and that allows it to function at the elbow. It's not really needed at the shoulder. The orders from the surgeon was for physical therapy 2 to 3 times a week, range of motion, full elevation, external rotation to full range, internal rotation to full range. I'm accentuating this because I'm going to show you what was actually done. The orders from the surgeon: active motion, active assistive, passive motion. Orders from the surgeon: strengthening the parascapular muscles and the rotator cuff muscles. And he ordered modalities: ultrasound and cryotherapy, cold. This patient came to our clinic 13 weeks post-op. She reported that she was seen in another clinic for 6 to 8 weeks, and they mainly exercised her right shoulder. She said they put her on a peddler thing, and she said, "My left shoulder had the surgery." Well, you need to strengthen your right arm too. So most of her exercise was the right arm. She told me that she was only given 3 exercises for the left shoulder. Now, if you can zero in on my left shoulder, remember the doctor ordered full range of motion. So in addition to doing the peddler with the right shoulder, which was not the shoulder that was operated on, she did report to me that she was given 3 isometric exercises for the left surgical shoulder. These were the 3 exercises. Watch my shoulder now and see if we're getting full range of motion. Pushing straight out against resistance, external rotation against resistance, internal rotation against resistance. Did you see my shoulder move? No. And she reported to me that The therapists at this clinic never touched her. Now, she came to me 13 weeks after surgery. The range of motion in her left shoulder the day we saw her was flexion 120 degrees. That was pretty good. I was surprised it was that much. Abduction, abduction, 97 degrees. That's out of 180. And she had pain, a lot of pain. So that means she probably were compressing the bursa, and she probably has bursitis. Internal rotation at 90 degrees abduction was only 15 degrees. That should be 90. External rotation at 90 degrees was 65 degrees. That should be 90. So what did we do? We put cold on it. We did 2 transdermal anti-inflammatory medications, iontophoresis with dexamethasone and phonophoresis, the ultrasound, with 10% hydrocortisone. And we have that mixed by a compounding pharmacist. They didn't touch her. To do range of motion at the shoulder, we always do some distraction. That's why I never use wall slides. If you slide your hand up the wall, you're getting compression of the joint while you're trying to move it. It works so much better to do distraction and then move it. We do massage, and I have my own indoor heated pool, so we do aquatic therapy also for range of motion and strengthening. In, I think it was 4 weeks, her shoulder flexion increased in our clinic by 27 degrees. The abduction increased 37 degrees. So we're probably decreasing the inflammation in that bursa. Shoulder internal rotation increased 33 degrees and shoulder external rotation increased 18 degrees. That was in 6 weeks, but she missed 2 weeks because of a family death. So it was really 4 weeks of PT. Now, help me, please, help me grade this. They exercised the right arm mainly, and her surgery was in the left shoulder. No range of motion exercises were done at all, although the doctor ordered that. They gave her 3 shoulder isometric exercises only. They did not touch her, so they did not do distraction. No modalities were used according to her. Okay, here's the grading scale. A, B, C, D, or F. How would you grade it? Get back with me. And what I want to ask is, how does this level of care affect all of us? If you go to a restaurant and you get a bad meal, you're not going back. If this is the only therapy somebody gets, what do they think of physical therapy for any future use? What are they going to tell their neighbors and their friends? How does this level of care affect our profession? Now, here's an interesting question. What can we and what should we do about it? I want to hear from you. You tell me what we should do about it. Thank you. This is Gloria Sanders again. I want to thank you for listening to my videos, and I invite your comments. All medicine should be a discussion, and that's how we get better at what we do. We need to be able to explain why we do what we do. There's no one way to do things. So I want to hear from you. I don't know what you're being taught in PT school now. So are your professors master clinicians? Maybe, maybe not. Have they seen patients in the last 15 years? Maybe, maybe not. So I want you to tell me what you're seeing, your new graduates. Tell me what you're seeing in your clinics. Tell me what you like about this. If you disagree with something, I want to hear it. And I'll get back with you. I want a lot of comments, and if I get them, I'll do a video of just responding to comments. Because I think medicine should be collaborative, and I think we need to share experiences And I'm trying to do that with my experience, but I want to hear back from you. So subscribe, like, don't like, let me hear from you.